Welcome to Women of a Certain Stage, the podcast redefining how we think about menopause. I'm your host, Lauren Churin, a passionate advocate for breaking the stigma and empowering individuals to navigate this transformational stage of life with confidence and clarity. Here, we're diving into a new era of menopause support, featuring expert advice, real-life stories, and actionable insights. Whether you're curious about building your personal menopause plan or you're looking to make an impact, you're in the right place. Let's embrace the change together. I'm really grateful because I know we were going to do this when you were back in the UK, but you ended up being in France this weekend. So thank you for getting it all to connect. How was your week? Did it go to plan?
I was very, very busy. I worked day and night on a lecture for my local Rotarians, which I was giving in French on censorship in medieval European art.
Oh, wow.
It went rather nicely actually because I love the artist Peter Bruegel, and whenever you go around all the galleries in Europe, you'll looking at the various different imageries. Some of them have been censored and some of them not, because at that particular time the men used to wear very prominent codpieces, and if they were in a Catholic area, which offended the sensitivities of the locals, then they would be painted over. And the most famous Bruegel collection is actually was owned by the Habsburgs, and it's in the Vienna Kunsthistorisches Museum. And all the main one of the main pictures is a peasant wedding where you have a bagpiper playing his bagpipes side on, and he has no codpiece at all. It's almost as if he's been circumcised, or in fact neutered completely. And if you actually go up to the picture and you photograph it in the right light and you get the reflections of the lights from the top, you can actually see the outline of his codpiece. And so I used this in a debate in the past about circumcision, and I actually redrew it back in using PowerPoint and restored him to his former glory, shall we say. Anyway, that took me a day and a night of almost continuous working, and it's actually just a sign of ADHD. You can hyperfocus, and actually ADHD is something that's quite important in relation to perimenopause because it tends to get worse, and that's quite often when it gets diagnosed. But anyway, that's by the by. Another thing.
No, it's not by the by at all. It's all interconnected in one way, shape, or form. And I was having a look at, after we spoke last time, I was having a look at your YouTube channel because you'd said to me, have I seen any of your lectures? And I have to say that there are so many people out there that talk about perimenopause, menopause. They talk about all the kind of very generic information that I think most people are becoming accustomed to and familiar with. But you definitely go into the areas that people are not talking about. And I think that I would definitely signpost people to go and have a look and have a listen.
Well, that's fine. I'd be delighted if people want to have a look at my stuff. Of course, it means that I get less. Sometimes it's paradoxical. I get less interviews to speak because they've already seen the video. But it really doesn't matter, because I think the more information we can get out there about how the perimenopause affects women and the people around them and their families and their loved ones and all the rest, then the more important it is. Because if you think about it, so many things go wrong in perimenopause for such a large proportion of women. Not all women. Some women are about 10, maybe 12, no, 10, 15% of women sail through the perimenopause, don't know what all the fuss is about. But pretty well everybody else has some sort of symptoms. Now, of course, there'll be some. It's almost like one of these amp voltmeters or sound meters. There's some that are right out at the maximum. They are absolutely at their wits' end. But perhaps the most interesting ones are the ones who have subtle symptoms that they don't realise and the people around them don't realise, but their performance falls off a bit, and it's just not noticeable, and they don't really do very much about it. And of course, but the ones that we tend to see, of course, are the ones who have the maximal symptoms. Go to their GP. Well, you go to their GP, get gaslighted, and then eventually end up with specialists, unless, of course, they're lucky enough to see a GP who's been menopause trained. Because I think I would sort of metaphorically take off my hat to and say that the best person to look after you through perimenopause is your GP if the GP's been properly trained. And the
Yeah, and
problem
it's
is,
interesting.
yeah, so I was going to say, the
Yeah,
problem is that most of them haven't.
exactly that. And I think I was very lucky to have a GP. And I don't know whether at the time he had done additional training or was just a really good GP, but I saw him the first time round and we talked about low mood. And the second time he did bloods. And then when I went back, he just said, you've had a premature menopause. And that was that. And he nailed it and put me
Ah,
straight onto
well,
HRT.
that's very impressive, because that's a slightly different thing than perimenopause. Because if you had had similar symptoms and you were actually perimenopausal, your blood test would have been completely normal.
Yeah, exactly.
Absolutely normal. I mean,
Exactly.
the only test that you really need to do in perimenopause is the thyroid function test, because sometimes that goes up. People get hypothyroidism,
Yeah.
and it's sometimes difficult to tell the difference between the two problems. But if you had a premature menopause,
Yeah.
and that was spotted PDQ by your GP, then the man wins a coconut, and or rather gets sorry he gets your lifelong appreciation and thanks, and good luck to him,
He
because
does.
it's difficult to spot. Although actually, of course, one of the simple ways you can spot it is that you stopped having periods.
Except the fact was, I had my son at 37. I fed him for a year, and then I was on contraception
Aha,
that where I didn't have a bleed, so I didn't know my
yes,
periods had stopped. So that was the kind of
yeah.
really interesting fact that he did pick
So
it up.
it was disguised. It was very cleverly
Yeah,
disguised by
yeah,
your
yeah,
circumstances and the long breastfeeding. And of course, some
yeah,
other people can, if they're on a bleed-free contraception, such as Depo-Provera, or a Mirena hormone coil, then the fact that they're not having periods will simply not be apparent. I mean, that will
yeah,
just be there. And then
yeah.
some of the other symptoms will kick in. Although, once again, that's a relatively small number of people compared to the women who are actually perimenopausal and have got cyclical symptoms. And of course, quite a lot of them will go to their GP and start thinking, could this be perimenopause? And the GP say, well, you're not having night sweats, so it doesn't matter, so it's not. And that's completely wrong, because, in fact, temperature control problems are just about the last thing to kick in before you eventually go right into the sort of the major bit of the perimenopausal transition. But the start of perimenopause, first thing to go wrong is cognition, which
Yeah,
of course is the
yeah,
first thing that's going to affect your business performance. If in fact business is your primary, is your major selling point, shall we say, is how to help people, not just through their lives, but also how
yeah,
through their professional careers.
yeah,
And it's just those minor things of not quite being on the ball, and
yeah.
then you start getting a few physical symptoms, extra joint pains, palpitations, and then you get a bit of extra anxiety, and you're not performing quite so well in your business meeting, and you're losing a few words. That's the point at which you need to go for help. And because if you think about it, anybody faced with those sort of subtle symptoms where they're just not quite performing, not firing on all
Yeah.
cylinders, it's quite normal, if you think about it, to get depressed if you don't have a reason for it. And if you then go to the GP and say, well, I'm a bit fed up because of this, and the GP will say, well, maybe you're depressed and you need some antidepressants, which is the worst possible thing that that could happen. Because antidepressants don't do the job. They actually flatten your mood, flatten your joy, flatten your creativity. They might help you a tiny bit with premenstrual suicidal ideation, but they're not actually going to do the job, and they won't affect any of the other systems. So
Yeah.
you have to be very wary about where you go for your advice. And in fact, that's actually probably why you need something like what you're doing, is you get people who advocate for people who are not clinical, they're not medical, but they just raise people's awareness. I think, well, I'm very glad that I went to, that I sat, enjoyed and joined in your training thing, your
Oh, of
sort of
course, I forgot. Thank you for doing that.
well, no, the open training thing. It was very, very interesting. And I think
Yeah.
the only one thing that I really picked up on was that when you're talking about menopause, you actually mean the menopausal transition, which
Yes,
so,
the whole
so,
thing.
so it's not, where the periods have stopped for a year and then you are officially defined as being in menopause. It's actually the 5 or 10 or sometimes even 15 years before that, where things
Exactly.
start to go wrong, and they often go wrong in a quite subtle way, which
Yeah.
starts making life very difficult. Actually,
Yeah. Yeah.
there's all sorts of great new material out there. In actually, some of it in very plain English and perfectly
Hmm.
understandable as to how these things affect people. Now, I'm going to
Do you
shut up for
think?
a few seconds. You give me some feed, and I'll I'll try and go on a rant somehow.
Oh no, I listen. You know, I can speak to you for hours on end. So I was really looking forward to this conversation. So there's a couple of things I would like to ask you, maybe today, maybe another time. But
Yeah.
do you think it's because people are not yet truly perimenopause aware that they end up going to the doctor for the joint pain and having an MRI, and then months later going for, thinking they're having a heart attack and going for an ECG at A&E, and then they have
Yep.
migraines, and then they go for a scan, and then no one's joining the dots, and they're not joining the dots and saying the word perimenopause or menopause to their doctor.
Yep.
They've got all these reports over 3 or 4 years that telling them that they're okay. And you talk about depression, but no wonder their anxiety is so bad
Well, that's
because.
right. Yeah. Of course, everything seems to be going wrong, and nobody can nail it. And therefore, it is particularly if on top of that you start getting a little bit of extra premenstrual syndrome, a bit of extra
Mhm,
cyclical mood problems. Putting all those things together is enough to make anybody depressed. It's, in other words, they're not. It's not a psychiatric depression. It's a reactive depression. It is normal to be depressed when faced with the
mhm,
early signs, and of course and the later signs as well, of
mhm,
perimenopause, particularly if
mhm,
nobody's diagnosed them. I
mhm.
mean, you could almost say that if any woman in her 40s starts to feel a bit off
Mhm.
in any sort of way, the first thing you need to think about is perimenopause.
Mhm.
The very first thing that you need to think
Do
about,
you?
because statistically, that's what's going to happen to most women.
Yeah, yeah. But what about the fact that all genders, our hormonal decline actually starts in our 30s. So, whether you're a man or a woman, whatever gender you are, you're beginning to have that hormonal decline from your mid 30s onwards.
Mm.
So, I'm just always curious whether perhaps there is an earlier start to perimenopause in the late 30s, or do you really think it is in the 40s that's
Oh,
more
no, no, no.
common?
I mean, the thing is that the textbooks will say it's 5 years before the actual menopause, so mid forties, which is not
Hmm.
true, because we see plenty of women who are in their late 30s where it's obviously
Yeah,
starting, and these are
yeah,
not
yeah.
necessarily women where one of the first questions I ask them is how old was your mum when she had her menopause? Because
Hmm.
although
Hmm.
it's not completely genetically predetermined, if your
Hmm.
mum had an early menopause at 45, then there's a
Hmm.
very strong chance that that's when you'll have yours. So you would expect that perimenopausal symptoms will kick in earlier. But there
Yeah.
are shed loads of women that I see, and that I've heard of my colleagues speak about from 35 onwards, who
Hmm.
are
Hmm.
not going to have their menopause for another 15 years, who start to get early symptoms of
Hmm.
perimenopause. And once again, the first thing to look for is cognitive problems,
Hmm.
just
Yeah.
forgetfulness. And if you add that into slightly worsening PMS, then you'll get starting to get the whole pattern.
Hmm. Hmm.
I mean, you said that in fact the first thing you mentioned though was joint pains, and they go to the rheumatologist or something like that, get all the X-rays or whatever it happens to be, and then nothing's wrong, and they get given anti-inflammatories or ibuprofen or whatever it happens to be, and of course. That's one of the first ways that I got into doing private menopause work, because I had a knee problem and I went to my
Hmm.
physiotherapist, and we
Hmm.
were
Hmm.
chatting, and when she asked me
Hmm.
what I did, I told her, and she said, "Oh, did you know that that women athletes are 8 times more likely to have an anterior cruciate ligament rupture than men?" And I said, "Well, that's
Hmm.
got to be hormonal." So I went away and looked it up, and guess what? Nearly all the ruptures happen on the day of menstruation, or
Yeah.
apart from another peak at mid cycle, which is a
Yeah.
small drop in estrogen. And some
Yeah.
women, it's interesting, some women don't just get a little bit of PMS, which is a few days of
Hmm.
mood change before menstruation, but some women also
Hmm.
get a drop in mid cycle as well. And
Hmm.
that's
Hmm.
sensitivity to falling
Hmm.
estrogen. There are lots of different
Yeah.
patterns, but that's absolutely
Yeah.
classic. And that's when joint pains can kick in. And also, there's a whole load of other things that go on at the same time. Oh, asthma. How about asthma? Let's try asthma. Did you know
Yeah.
that 25% of all hospital admissions for near fatal and fatal asthma occur on the day of menstruation? Now,
Wow.
you don't have to be an immunologist or a chest
Yeah.
physician to be interested in that. And the reason is this: that anybody who's ever been pregnant knows that when you're pregnant, you have 10 times more estrogen in your body than at any other time. And that estrogen does all sorts of things to your cartilage. It softens your cartilage, particularly it softens your symphysis pubis. It also makes your ribs bigger because the intercostal cartilage is increased in length, so you can
Yeah.
breathe off the CO2. But when that's all taken away,
Yeah.
then everything tightens up. And so in a normal cycle, in the second half of your cycle, you've got plenty of estrogen around, so your joints are much better off. And then in the last week or so of the cycle, the estrogen drops and finally goes to a very low level at the on the day of menstruation, which is when your joints will become more painful. And also, if you've got asthma, your bronchi will become less flexible. So just a quickie. If you have got serious asthma, you must carry your inhaler and your preventer with you around the time of menstruation. Absolutely
Yeah.
critically important. I mean, that's a very. I'm sorry. This is a very small print thing in a very very large field. But I'm just giving you one example, if you like, of how massively estrogen affects all aspects of your bodies. If we just take us I'm now going on a real sort of a riff
I
and
love it. You
almost like
keep
an
going.
ADHD riff and a rant, and I've done this in one of my previous lectures. Okay, so here we go. So we've gone from death from asthma and ACL rupture. Also, opera singers have it written into their contract that they don't have to perform in the week before their period. Why?
I did not know
Because
that.
because because estrogen loss affects the cartilage of the larynx, and you lose half an octave off the top of your scale. Now
Keep going.
that doesn't matter
Keep going.
that doesn't matter to you and me, but it matters to people who are professional singers. Now the reason I'm saying this is not that it really matters that much, but what it shows you is how subtle some of the signs can be. But they're really actually very, very important. And if we come back to the athletes, it means that any woman who's doing a 5K, for instance, on a regular basis, needs to
Yeah.
warm up for 3 times longer before she starts the run when she's about to menstruate. So all of I mean, that doesn't matter whether you're perimenopausal or not. Any woman would need to do that.
Yeah.
Any sportswoman would need to do that. But
Yeah.
anyway, sorry, we are now
I
really going off on a rant. But what it's showing is how important estrogen is to every bit of your body. And that
everything,
people have got to
everything.
nail that. People have got to know that.
And I think that one of the things we do at the beginning of our diploma is we talk about estrogen, the power of estrogen, what it does in our bodies. And one of the things I do is I work with female rugby players and female football players, and female cricketers as well. So we look at and we use Aura rings and we use other diagnostics to look at what their body temperature, what their heart rate variability is, what their BP is. Like we look at all of these statistics so that we can map out their cycle and change their training based on where they're at on their cycle. So it's so important.
I was going to say not many people do that, and that's actually very clever.
Yeah,
Very,
yeah,
very clever
yeah,
indeed.
yeah.
So
And
if I mean, in fact, actually, the physiotherapists I work with used to work for Bristol Rugby, so they're completely attuned to that sort of thing.
yeah, yeah. And I love it. I mean, even with my ring, although I'm nearly 20 years postmenopausal, I check my body temperature every morning, because if I go plus 0.1, plus 0.2 over 2 or 3 days, I know that I've got to take more care of myself and up my self-care, especially when I'm traveling a lot and working long hours. I know that it's very easy to burn the candle at both ends, but as soon as I see my body temperature going up, that's my sign that I need to just slow down and make sure that I take care of
That's
myself
very
again.
interesting. I never thought of that as a particular parameter to be looking at. Well, that's something I'm learning. I mean, there's so much more for me as a bloke to learn. Actually, that comes back to why I'm doing what I'm doing, because as a gynecology registrar, I never learned any of this. I only learnt this first of all by marrying one of the world experts on the subject and getting
Yeah,
taught by her, and then by listening to lots of women telling me their stories. And that's why I enjoy
yeah,
doing the work so much, because the stories are fascinating. The histories that they give are similar, but no two women describe them in the same way.
Yeah.
And
But this,
it's the wonderful use of words and the turns of phrase that they come up with to describe their various symptoms that make it
uh-huh.
absolutely fascinating.
But this was your second big field, wasn't it? So initially, when you
Yep.
trained, what did you go
I,
into and why?
well, no, I trained in the gap between gynecology and sexually transmitted infection because,
Yeah.
first of all, a personal thing, just about everybody knew in the 70s managed to get chlamydia.
Mm-hmm.
Because it was the 70s and every woman you met was on the pill and there was no teaching about using condoms, and thank God we didn't have to worry about HIV, so we just got on with it.
Mm-hmm.
And I was brilliantly looked after because I was shit scared the first time I got something, and I was really very
Mm-hmm.
worried indeed. But I then saw the women friends around me going to very, very unsympathetic, unfriendly doctors
Mm-hmm.
who were well terribly judgmental about what they were doing. It was a double standard
Mm-hmm.
morality.
Yeah.
It was okay
Yeah.
for the men to mess about, but not for the women. And
Yeah.
I thought this is massively unfair. And it got even worse because the college where I did most of my socializing had chosen for its doctor a staunch Roman Catholic, late middle-aged, staunch Roman Catholic. And you can imagine how damaging that was for the women around. And if you are the male significant other, male partner of a woman who feels effectively as if she's been mentally
Yeah.
raped, you get angry on her behalf, and
Mm-hmm.
you want to kill the bastard.
Yeah.
And that was my attitude. And I couldn't,
Mm-hmm. Mm-hmm.
I didn't care what I did. I could see that a huge injustice was being done to my partner and to her friends and friends of friends and everything. And I thought any
Mm-hmm.
idiot could do it better than it's being done at the moment. And so I decided I wanted to try and put sexually transmitted infections together with contraception and medical gynecology. And effectively, I was the
Mm-hmm.
first person to do it, the first person to set up an integrated
Yeah.
sexual health service at Ipswich when I got my first job, and then did much the same in Bristol and Weston when I
Yeah.
moved down there. And so that's where I'm coming from. I'm not a gynecologist. I'm not a sexually transmitted infection specialist. I'm both, if you see, a
Mm-hmm.
gynecovenereologist
Yeah.
in European terms. So
Mm-hmm.
it's a trying to bridge the gap
Mm-hmm.
between the two subjects, and the women were just falling down between the two all the time.
Mm-hmm.
And I think I think I've had a reasonable amount of success in doing it because the subject's called sexual health now. It
Yeah.
wasn't like that
Yeah.
40, 50 years ago. But anyway, that's where I'm coming from. But I did that effectively for 20 years, and then got into serious, shall we say, further women's health, a
Mm-hmm.
more
Mm-hmm.
detailed women's health by understanding menopause in much better detail, simply by marrying into it.
Yeah. What better way?
But
So
quite.
I'm curious, how have you seen the sexual health world change over the years? Because you've seen it from perhaps some of
Oh,
its darkest times to
well, yes.
hopefully better.
Well, no, the thing is, it's actually getting darker and darker now because, of course, having lived through untreatable HIV, when HIV became
Mm-hmm.
treatable, people started to get little bit less worried about infection. And then when we got to the point where HIV was, if your HIV is suppressed, your viral load suppressed, undetectable is untransmittable, then it becomes even less of a worry. And of course, rates of HIV are going down dramatically, which is brilliant. But at the same time, the sexually transmitted infection rates are going up because
Mm-hmm.
thanks actually to these wonderful devices. Because it's in fact it's all due to Uber. You know why? Because
Tell me more.
remember how difficult it was to get a taxi back in the day.
Yes,
Now, thanks to Uber, it's easier to get a ride.
just like that.
Yep, and it's the same thing, and it's the if you take the metaphor, it's the fact that you can actually geolocate somebody in a restaurant
Mm.
or a bar or something like that to within a few meters, somebody
Mm-hmm.
who might be interested.
Yeah. Yeah.
And also the other thing, of course, about the dating apps is that it means that people can get over that initial embarrassment of what
Mm-hmm.
do you say if you were to meet somebody in real life
Yeah.
and you actually might fancy, that you're interested in them. When you
Mm-hmm.
make
Mm-hmm.
that opening gambit, it's embarrassing.
Mm-hmm.
You don't want to get it wrong. Now, the nice
Yeah.
thing about doing it with a phone is you can do it by text,
Mm-hmm. Mm-hmm.
and you can be as suggestive as you like. And if for some
Yeah.
reason you
Yeah.
overstep the mark,
Yeah.
boom, next please.
Yeah. Yeah. Yeah.
Whereas if you are actually being a little bit more forward than you would normally be in real life,
Mm-hmm.
why on earth is the other person on Tinder or whatever it is in the first place? They may be up for the same sort of thing. So your
Mm-hmm.
chances of, how should we say, your chances of success are much greater. And to put it in even simpler English, you can change partners quicker. And the quicker you change partners, that is the
Mm-hmm.
limiting step that determines as to how quickly sexually transmitted infections will spread. Particularly if you're back in the sexual marketplace in your 40s
Mm-hmm.
or 50s, and you're less likely to be using condoms.
Mm-hmm.
Maybe you don't need to use them from the contraception point of view. That's another thing
Do you,
to think of
do
as
you think
well.
is there a spike? Are the statistics saying there's a spike in older adults sexually health?
Oh yeah, absolutely. Well, a
Yeah.
spike is probably not a very nice way of putting it. There's a bump or
A
there's a
thump.
hump. There's a hump. If you look at
Oh God.
if you look at the statistics, you can describe it. There's a lot of comedy you can make out of it, but actually it's deadly serious, because if you actually look at if you were to draw a graph of what happens to cognitive function through the menopausal transition, it's here, then it goes down, and then back up again, not quite to where it was. It's the dip. That
Mm-hmm.
dip happens in early 40s, or whenever somebody's
Mm-hmm.
perimenopause starts. And the bottom
Mm-hmm.
of the dip corresponds with highest rate of divorce,
Yep.
higher rates of some sexually transmitted infections when you measure them across a whole population, not by
Mm-hmm.
attendance at clinics, but if you do epidemiological studies.
Mm-hmm.
It also is the point at which you have the highest suicide rate in women,
Mm-hmm.
because
Mm-hmm.
they're getting their perimenopause misdiagnosed and mismanaged. They're getting antidepressants and not
Yep.
hormones, which is effectively
Mm-hmm.
what they need. So all of this
Mm-hmm.
comes together on average in mid 40s.
Mm-hmm.
And I think 44 is the peak age for divorce. And of course, when people, if you think of the run up to the divorce, it's not just lack of libido, because not everybody suffers from lack of libido, although in fact a
Nope.
very sizable proportion of women do. But people are looking around for new, shall we say, new opportunities or new avenues, or they're just
Mm-hmm.
absolutely fed up and the partner's gone off anyway.
Mm-hmm.
And so there are more infections around because of the dynamic of what's going on, and the relationships are fluid, and the power in relationships is changing as well. I was actually
Yeah.
just listening to a really good podcast this morning. You probably know Kate Muir, who's
Mm-hmm.
actually probably the most important of the menopause warriors, because she produced the Davina McCall documentaries,
I
which
had her on my.
well, good, but then you
Yeah.
know. But
Yeah. Yeah. Yeah.
something I heard today, she's just been talking to a divorce lawyer
Mm-hmm.
about how difficult things are for women specifically going through divorce,
Mm-hmm.
and how they're not getting an appropriate divorce settlement, because their employment opportunities on average are less than they would otherwise be, because they're perimenopausal, because they've got cognitive decline, etc., etc. So there are just so many things that are actually piling on together at the same time. Actually, it's better knowledge and better appreciation of what's happening, which is actually
Yeah.
enormously important. And then there's an Australian study published only a few days ago in the Lancet, which
Mm-hmm.
shows exactly this: that the worst time
Yeah.
for cognitive decline and other issues is early perimenopause,
Mm-hmm.
rather than menopause itself, or pre perimenopause, if you see what I
Yeah.
mean. So it's the
Mm-hmm.
early stages of perimenopause, because those are not being recognized, and women are going through that and not getting any help, or that they're getting the wrong help, or they're doing the thing you were describing earlier about chasing around all the various different symptoms and actually
Yeah.
not getting a diagnosis. So
And that's what I hear all the time from women. Yeah.
yes. Each woman's story is going to be slightly different, but they will have,
Mm-hmm.
depending on their symptoms, and also depending on
Mm-hmm.
what sort of response they get from their GP. But
Yeah.
of course, I have to say though, I see a biased selection of women. By definition, I'm seeing women who are not being well managed by their GPs. So the ones who are being very well looked after, I don't see them at all. That's fine. I mean, and actually, the numbers of people who come to see me have reduced recently, and I suspect that's because a lot more GPs are getting the right training, and that's good news. That's first bloody bit of good news we've had in a long time, actually, in relation to perimenopause, apart from better awareness of it. But the fact that
Yeah.
if you've got a GP who's on the ball, then that is your best possible asset.
Yeah, I think, I mean, as I said, I was very fortunate that he nailed it very quickly. Within 3 months, start to finish, identified, put me on HRT, and I didn't go on with HRT, so I have been without hormones for 20 years. And clearly, I should have been on hormone replacement therapy until I was at least 51, but I wasn't. So I'm dealing with that as best I
Well,
can right
if
now.
you are if you are thriving despite not being on hormones, then congratulations, well done to you. Particularly if you've had symptoms that you've had to work for, work at, and I suppose nutrition and CBT and mindfulness and a whole load of other and exercise and a whole shed load of things that will actually help. The trouble is some women's perimenopause or menopausal symptoms are too, shall we say, too strong to be helped by all the other supportive stuff, and they absolutely
I
are going
agree.
to need HRT, and of course take it for life.
Absolutely.
I mean, the
Yes.
worst thing you could do is to get your GP to say, "Oh, you've had it for 5 years and you've got to stop." All those things that came in with the misinformation around the disastrous Women's Health Initiative and the Million Women study in 2002, 2003. All of the standard sort of mantra was lowest dose for the shortest time, no more than 5 years, and stop when you're 60. Now, each of those particular lines is wrong. So it's as much as you need for as long as you live. That's my particular mantra, and it's now been borne out by the most recent statistics and the most recent findings from really long-term studies in America. But it's actually happening. I can see it in real time with my people of my generation who are now in their late 60s, early 70s, and if you can always tell a 70-year-old is on HRT because she looks and acts 60. And when these women, when my friends are going to their 50th or 40th or 50th year reunions, college reunions, they can look around the room and you can immediately spot the women who've been taking HRT.
See, I thought it was just Botox.
No, because these women tend to be, they're walking taller, they're thinking faster, they're probably living more independently, and they're by and large in far better health. Of course, I mean the one thing that you can be confident is that their bones are going to be rock solid if they've been taking HRT for 20 years.
Yeah, and that's the one thing I definitely need to go and get a DEXA scan because 20 years postmenopausal and I haven't had my bones checked, so definitely got to put that on my agenda.
Maybe on a podcast we don't want to get too medical about these sort of things, but if you've found that you've had problems with estrogen, and there are some people who do, there was one American study, brilliant American study, where they used minuscule doses of estrogen. Mini doses. You know that if, for instance, you're taking a patch, and patches come at 100, 70, 50, 25, right? The Americans used a 14 patch with no progesterone, including in women who had a uterus, and they used it just for a few years, and the bone densities went up, even with the tiniest amount of estrogen.
How many people were in the study?
Oh, I don't know, several hundred. And so any amount of estrogen that you can take, even the tiniest amount, half of a 25 patch would be enough if used over several years to prevent osteoporosis. Fascinating.
Yeah. It is
But anyway,
fascinating talking to you. No, it is fascinating talking to you because obviously I'm talking to doctors all the time and talking to people from the British Menopause Society, talking to a lot of private doctors, talking, lots of different opinions. Rather than, my question isn't about what's right and what's wrong. My question is, how does a layperson make sense of the conflicting information that they see online or that they listen to in podcasts?
Damn difficult. I mean, actually, one of the most important things that people need to try and almost fight against is the food supplements industry, because that's where people are throwing an awful lot of their money away. And there's probably only one food supplement that the average person, male or female, in midlife needs, and that's vitamin D. And and interesting, we had a big meeting in Paris recently, English speaking meeting from people, for expats, and with education around it, and that was they were showing a film produced in the States, which actually is a very good film, but it was sponsored by I think it was sponsored by sort of food supplement industry, or the nutritional supplement industry, and they had one bit of it which was completely wrong, and a woman said, you'll do very well on these extra nutrients because they've all been scientifically tested, and in fact they haven't been scientifically tested, or haven't been tested in randomized trials, and the evidence actually is that almost none of the additives makes a blind bit of difference. If you've got a normal diet, if you're not unless you're actually a very, very strict vegan, if you've got a normal Western diet, then the only thing you need is vitamin D, which is interesting. So that bit of misinformation is actually quite, well, I was going to say quite difficult to swallow, because it's given in such a professional. Sorry. It's pun intended. It's very difficult. But then you're now saying, about different doctors saying, well, how long should you take it for, and also which.
Well, just completely different opinions, actually.
Well, you have, in some ways, it's almost as if you have to find an opinion that suits you. What do you want? I mean, what did you? Some women actually say, "Give me everything. Give me absolutely everything." I was at EMAS, the European Menopause and Andropause Society in Valencia, and I met several women who were really very strong menopause warriors. And these women there was one woman in her late 30s who was already on testosterone, and I don't know whether she really needed it, but she said, "I'm going to take everything I need until the day I die." She'll probably have very, very strong muscles and very strong bone density. God knows what will actually happen to her, but I think there are some people who are very strongly advocating for it. But I'll stop. I'm going to stop myself right there metaphorically and say that there are some women who do exceptionally well without HRT.
I hope so, because
oh no, there are.
I'm now imagining. I'm imagining myself walking into a reunion in 10 years when I'm hitting my 70s and going, I'm the little old lady who's all stooped and bent over. I'm just hoping that, my gym and my everything else is going to do something good.
Lauren, with great respect, you seem to be doing pretty well up to now, but you can take that any way you like. But I think that the thing, the one anecdote I will tell you, I'd just given a lecture to, in fact, a group of Rotarians in Bristol about all the misinformation about HRT and how the adage should be as much as you need for as long as you live. And the most astute question from the audience came from a woman in her 80s who was absolutely pin sharp as a button, looked fit, healthy, and all the rest, never taken HRT. And so some people can wear it very well indeed. And the question was, does everybody need to be on HRT? And the answer is no. The answer is no, but the majority will benefit from it. Of course, then you have to try and make the decision yourself and make it on the best information you can get. And once again, that comes back to your question: where do you get the information, and from whom do you get the information? Very difficult. Very difficult indeed. There's no easy way of doing it. Actually, I'd follow people like Kate Muir, because she's certainly on the right track. Although when she performed she was doing a live show in Bristol, she was with a writer who herself was not on HRT, who said that the menopause was transformatory, because when she went through menopause, she lost her PMS. And so she became much more calm and much more stable psychologically, and was able to write better. Whereas Kate herself had a disastrous perimenopause, then got onto HRT and got completely sorted. And she's soared since then. So different strokes for different folks.
Definitely. Yeah. I think the biggest thing for me postmenopausally is the increase in confidence. It's that ability to just decide, this is what I want to do, and I'm going to go out into the world and do it, and there's no stopping me. Obviously, when I say there's no stopping me, I can't see anything stopping me, but I've been doing it for 12 years, so I couldn't have done this work before I went through menopause.
Well, I was going to say, you need a very strong mindset, and particularly if there's nobody out there to support you, although apart from your GP, interestingly. Of course, that actually has probably been your lifeline, hasn't it? In all the, in other words, you've got that validation, and obviously they're looking out for you for all the various different systems that could go wrong. But it's intriguing, and you're making an enormous effort, because it's actually probably harder work for you, because you can't just dip into the HRT because you've tried it and it obviously doesn't work for you.
Yeah. Who knows? I mean, I only had that 1 month of being on it. I didn't have the chopping and changing and trying and finding the one, which is probably what I would do now. But so far so good. And the podcast is definitely not about me. It's about hearing your views and your stories and your anecdotes and your hilarious sense of humor, which I adore.
Well, no, it's the ADHD sense of humour. I mean,
I'm going to just ask.
actually, it comes back to my background, as I did 6 years of comedy at Cambridge and a bit of medicine on the side, and so I enjoyed my time there a lot. But the most important thing that happened to me was that I got trained properly. You know how it is, if you play a game of sport in a team with players that are better than you, it raises the standard of your game. And I did comedy with people who are now some of the greats of modern comedy. The people who wrote Outnumbered and Drop the Dead Donkey. So that's Andy Hamilton and Guy Jenkin. And then Paul Mayhew Archer, who did The Vicar of Dibley. So these people were great at that point, and I learnt my comedy, which I now use in my lecturing, from these guys. And and I had my skill of graphic design, which is what I was doing, and then I got into it from there. And that's what I now use in my consultations. Just interestingly, what we're doing now is not too dissimilar from my consultation style, because if you had a medical student sitting there watching, they'd think I was just having a conversation with somebody there in the pub or in a restaurant, rather than doing tick box medicine, which is sadly what a lot of people have to do nowadays with the computer. Because actually, that was one of the reasons I left. Certainly, I left being consultant at Bristol, because we went computerized and there wasn't enough training to do it, and I can't touch type. So half of the time. And I've got a screen over here, so I'm doing this, and I'm just doing this, and I have no time to teach a medical student, only time to type stuff into the computer, and then consultations taking 3 times longer, and having far less eye-to-eye communication with the patient. I couldn't stand that at all, and that's
Amazing.
one of the reasons that another reason for retiring and just doing things privately.
I hate to do this. I hate to do this because we're unfortunately at a time, and I'm going to just close. I know. I would love to have another conversation with you, and another. But anyway, I'm just going to close out by asking you, what does your next few years bring for you? Because when we first spoke, you said, "Well, I'm semi-retired." And yet, I just hear you talking about all this incredible work you're doing. So, what does the next few years look like?
The next few years look like, well, I'm getting more and more invitations to lecture at conferences, which is in fact my big hobby. And I will do more of that. Hopefully, as long as people will have me. I mean, you're only as good as your last lecture. And of course, if you post too many of them online, then people have already seen them and they know what's coming. But no, I think my stuff is always evolving. So the thing that keeps me going is that there will be more conferences to go to, more places to visit. And whenever you go to a big conference, there'll be a nice art gallery, so you can check out stuff in the art gallery and the socializing and all the rest that goes with it. And the fact that I do private menopause appointments, and I've got got an hour to chat with somebody. And in fact, the great thing is to sit back and listen to their story. Remember, of course, I have a tremendous advantage over an average GP, because how could you possibly do a menopause appointment in 10 minutes and put it into the computer? It can't be done. It can't be done. I know that, in fact, most of the doctors, the menopause-trained GPs that I speak to, say they deliberately take longer, and they do it over 2 or 3 consultations. You can't just do it in one. But I have a luxury of just being able to sit back and listen to the woman pouring out stuff that she's mostly held in for a long time, and getting her just listening to women articulate about their problems is fascinating, because I've had, like a professional and social desire to make life a little bit better for the women around me. And that comes back to, way back to my childhood, seeing my mother having a bad time and feeling sympathy for and
Amazing.
support for her. And that's where it comes from. So that's what
Peter,
I've got to, hopefully, what I've got to look forward to for the next few years. But, and another podcast, perhaps.
oh yes, oh yes. I think the more you put online, the more people, it's just whetting people's appetite. It's just your advertising, it's just letting people know that you're available to come and do an amazing lecture for them. So, Peter
Yeah,
Greenhouse, thank you so much for your time today.
it's
I
been a
really
delight.
appreciate, and I wish you a great week ahead.
Okay, thank you.
Thank you for joining me on Women of a Certain Stage. I hope today's episode inspired you to think differently about menopause and the incredible opportunities this stage of life brings. If you enjoyed this episode, please share it with 3 friends who need to hear this message. Don't forget to like, subscribe, and leave a review. It helps us reach even more people. You can connect with me on LinkedIn at Lauren Turin, or visit our website at womenofacertainstage.com to learn more about menopause coaching, inspiring events, and corporate training. Until next time, let's continue making a difference, one conversation at a time.